Hello, my name is Ann Borders. I'm a maternal fetal medicine physician and the executive director of the Illinois Perinatal Quality Collaborative. Our collaborative is working on an initiative, Mothers and Newborns Affected by Opioids, in order to provide optimal care for women with opioid use disorder and their newborns. Today, I'd like to share an eModule with you that explores the critical role of the OB provider and clinical team in caring for women with opioid use disorder. Purpose of our eModule today is to review the background on opioid epidemics and the implications for perinatal care, understanding how opioid overdose has become a leading cause of maternal death. We will then go into some of the key treatments for women with OUD, understanding screening and linking to care, OUD protocol implementation, the initiation of a clinical algorithm and clinical care checklist, providing patient education, and the need for staff education to reduce stigma. And finally, talk about some key strategies and clinical care team roles. The opioid epidemic has been hitting our country and exacting a terrible toll. The rise in overdose deaths has been something that the medical community has had to grapple with, both our role in prescribing opioids and the impact on our patients. Pregnant women and postpartum women have not escaped this crisis. Opioid overdose is now the leading cause of maternal death in Illinois. In 2016, there were 10 maternal deaths related to opioids. In 2017, 20 maternal deaths related to opioids. And while maternal deaths from any cause are tragic, when we think of postpartum hemorrhage, postpartum hypertension, all the causes of maternal death that we focus on. In 2017, there were 6 deaths from hemorrhage, 6 deaths from hypertension, and 20 maternal deaths related to opioid use. Many of these maternal deaths are preventable. I think one of the challenges with the opioid epidemic is the stigma. And I think it's important for all of us to understand that opioid use disorder can happen to anyone. 20.5 million Americans have a substance use disorder, and 2 million had a substance use disorder involving prescription pain relievers, and 500,000 had a substance use disorder involving heroin. This is a widespread problem that does not pretend to one demographic that can really truly affect anyone. When we think of doing the hard work to change how we care for women with opioid use disorder and truly provide optimal care, we need to remember the women that we're doing this work for. We are trying to prevent maternal death. We are trying to improve pregnancy outcomes for these moms and their newborns and their families. And we need to remember the women who've lost their lives to the opioid use disorder. These are the women that we have to keep in mind as we try to understand how to provide optimal care for women with opioid use disorder. In order to provide optimal care for women with opioid use disorder, we need to understand that it is a chronic treatable brain disease and that it can be managed successfully by combining medications with comprehensive care and recovery support. Treatment enables those with opioid use disorder to regain control of their health and their lives. I think it's important to understand that medication-assisted treatment allows women to really move toward the road to recovery. When women are taking opioids, it changes their brain chemistry. It really creates a brain disease. When women initially take opioids, it can be for pain relief and it can create euphoria. But very quickly, the brain changes. And women are no longer taking that opioid for pain relief or euphoria. When the brain changes, very quickly, as addiction happens, women are taking the opioid to feel normal. And when they don't take the opioid, they feel very sick. We treat women with medication-assisted treatment to break that chain and help recover and improve the brain chemistry so women, as we say, can go onto the road to recovery. This is really an important element of understanding why we move women into medication-assisted treatment. Medication-assisted treatment, or MAT, is the standard of care for opiate use disorder in pregnancy. It is endorsed by the American College of OBGYNs as the optimal treatment for OUD during pregnancy. All OB providers should understand that methadone and buprenorphine are safe and effective treatment for opiate use disorder in pregnancy. The goals of treatment with MAT are to alleviate signs and symptoms of physical withdrawal, diminish and alleviate drug cravings, and most importantly, normalize and stabilize perturbed brain neurochemistry so that women can move into recovery. In order to understand opiate use disorder as a chronic brain disease, it's important to understand the pathway to addiction. When women first use opioids, they can move from feeling normal to having euphoria. But that feeling of euphoria to normal only lasts a short amount of time and really only represents acute use. When someone uses opioids over time, they begin to develop withdrawal symptoms. So that as they take opioids, it makes them feel normal. And when they're not using, they move into withdrawal. This is that altered brain chemistry that leads to addiction. And this is why treatment for substance use disorder works. When women take medication-assisted treatment, instead of moving from withdrawal to normal and back to withdrawal, or even from normal to euphoria, they just feel normal. And this is so important as a tool to stabilize brain chemistry and move women into recovery. MAT has many benefits for both moms and their fetus. Very importantly, in addition to moving women into recovery, it is so important that we understand that it has significant reduction in risk of overdose deaths. It decreases risk of HIV, hepatitis B, and hepatitis C, increases engagement in prenatal care and recovery treatment, and other services that women may benefit from during pregnancy and the postpartum period. Being on MAT increases the number of women who can parent their babies. And for the fetus, we see many benefits, including reduction in fluctuations in maternal opioid levels, which can reduce fetal stress, which is thought to reduce risk of intrauterine fetal demise, intrauterine growth restriction, and MAT has also been associated with reductions in preterm delivery. For women who are pregnant and postpartum, medication-assisted treatment saves lives. This study from Massachusetts shows in the gray overdose events when women are not on medication-assisted treatment, and in orange overdose events for women who are on MAT. And you can see about a 50% reduction in death for women on medication-assisted treatment. And importantly, you see that overdose deaths increase in the postpartum period. This is a time of great risk for women, and why it is so important that we take the opportunity of pregnancy as a window to identify women with opioid use disorder and get them started on medication-assisted treatment and into recovery treatment services and programs, and then continue to follow them closely through that postpartum period and beyond. It's really important that we understand why the postpartum period is so risky, and so that we can better take advantage of pregnancy as a time to identify moms and get them into treatment. We know that there's an increased risk of relapse in the postpartum period, and women may have a reduced tolerance, which increases their overdose risk. There can be a reduction in support services and resources postpartum compared to what women have been experiencing during their pregnancy. Also, for women who have babies with neonatal withdrawal, who are maybe in the hospital, they're experiencing shame and stigma, particularly if healthcare providers are not treating them with empathy and respect and engaging them in their newborn's care. There are high rates of co-occurring depression, anxiety, and social issues, which can be exacerbated after delivery. And that is why our goal is to have moms in treatment on MAT with recovery services, a Narcan prescription, and close postpartum follow-up. Safe discharge planning for mom and baby saves lives. Now let's go over some of the key clinical strategies to provide optimal obstetric care for opioid use disorder in order to promote recovery and reduce risk of maternal death. The Mother and Newborns Affected by Opioids initiative, led by the Illinois Perinatal Quality Collaborative, was launched in May of 2018 with over 100 Illinois hospitals in order to promote optimal care for mothers and newborns affected by opioids, with a goal to reduce maternal risk of death from overdose and improve pregnancy outcomes. The goals of this initiative in order to improve optimal care include increasing the use of universal validated screening for substance use disorder and opiate use disorder, both as early in prenatal care as possible and on arrival into labor and delivery. Increased over 70% of patients being on medication-assisted treatment during pregnancy or by delivery discharge, and have over 70% of patients with opiate use disorder linked to recovery treatment services during pregnancy or before delivery discharge. In addition, the OUD clinical care checklist, which we'll go over, is really an important component in order for the OB clinical team to understand the key clinical elements they need to put in place in order to improve health outcomes for mom. These include providing a Narcan or naloxone prescription and providing a hepatitis C screen. And finally, it's so important that moms receive patient education on opiate use disorder and neonatal abstinence syndrome. And this is another goal of the initiative. We have very specific concepts that all obstetric providers need to understand about opiate use disorder. Opiate use disorder is an urgent obstetric issue. This is not an issue that is someone else's problem. This is the leading cause of maternal death in Illinois, and every patient with opiate use disorder who's identified during pregnancy or the postpartum period is an urgent obstetric issue and a risk for maternal death if optimal care is not provided. Opiate use disorder needs to be seen as a life-threatening chronic disease with life-saving treatment available. And we know that reducing stigma improves outcomes. Third, there are key steps that all obstetric providers need to take prenatally and on L&D to care for women with opiate use disorder. And finally, linking moms to medication-assisted treatment and recovery treatment services reduces overdose deaths for moms, improves pregnancy outcomes, and increases the number of women who can parent their baby. The MNO OUD Protocol lists the key steps that every obstetric clinical team needs to take when caring for a woman with opiate use disorder. First, they must screen with a universal screening tool and document a positive result. Next, provide expert risk assessment. This simply means going in and talking to the patient. When a woman is identified with risks for opiate use disorder, the OB provider needs to walk into the room, address the risks, assess the diagnosis, talk about the benefits of treatment, review the goals the woman has for her pregnancy, and then assess her readiness to start treatment and link to recovery treatment services. Next, we need to activate care coordination and navigation to successfully link women to MAT and behavioral health counseling recovery treatment programs and close obstetric follow-up with warm handoffs. The clinical team needs to identify the OUD clinical care checklist and complete or start the checklist and insert it into the patient's chart. This is very important so that over time during pregnancy care and during labor and delivery care, it's clear which of the key components of OUD care have been completed. And finally, we need to provide the patient education regarding OUD and NES and engaging in newborn care. This can be done with handouts that are available through Ilpqc, with patient education materials, and in neonatology consult. Remember that activating the OUD protocol for every screen-positive mom will reduce maternal death, improve pregnancy outcomes, and increase the number of women who can parent their baby. OB providers have a unique opportunity during pregnancy to provide optimal care for all women with OUD. Remember, we must screen every pregnant patient for OUD with a validated screening tool and document the result during pregnancy and during the labor and delivery admission. We must assess our patients for their readiness to start medication-assisted treatment, and we need to start MAT and link them to a recovery treatment program. We should provide naloxone, Narcan counseling, and a prescription to every patient with opiate use disorder or who takes opioids regularly. We must screen all patients with OUD for hepatitis C. Warm handoffs for MAT and recovery treatment services and close OB follow-up are necessary. And finally, we must provide patient education on OUD and NAS and reduce stigma and promote empathy across our clinical team. These are the key elements that every OB clinical team must understand and follow in order to provide optimal care for moms with OUD. So let's go through some of these key elements. First, universal screening for substance use disorder and opiate use disorder with a validated screening tool. Universal screening with a validated screening tool is recommended by ACOG, SMFM, and ASAM. We must screen all pregnant women on entry into prenatal care and on admission to labor and delivery and document the results. The validated screening tool is the best way to identify risk factors for opioid use disorder. It allows for the earliest possible intervention and referral to treatment. Remember, the goal of screening is to identify pregnant and postpartum women with a life-threatening illness, opioid use disorder, in order to start treatment early in pregnancy or, if identified during labor and delivery, before delivery discharge. We talk a lot about SBIRT, screening, brief intervention, and referral to treatment. But in the end, all it is going in and talking to your patient. When someone screens positive for a risk factor that could be a potential life-threatening illness, we must go in and talk to our patients and assess their readiness for treatment. SBIRT are the key steps that OB providers need to respond to all screen positive patients with substance use disorder, opiate use disorder. It can be very brief, a less than 5-minute discussion to provide feedback and advice. It has been shown to be a very powerful tool to help patients change behavior. You must assess the OUD diagnosis, briefly discuss risks of overdose and neonatal absence syndrome, and the patient's goals for her pregnancy. And most importantly, assess readiness to start treatment and link to recovery treatment services. We must refer these patients to start MAT and recovery services with warm handoffs and close follow-up. And there's an SBIRT pocket guard that many providers are utilizing that's available through Ilpqc if you need additional assistance in the steps or the counseling needed. I'm going to go briefly through an SBIRT. This one is involving marijuana to show how you can do an SBIRT with a patient very quickly and effectively. Thank you for asking these questions. I noticed you're occasionally smoking marijuana. Is it okay if we talk about marijuana use and pregnancy? Sure. People use drugs for many reasons. Can you tell me what you like most about using marijuana and what you like less? I do like the way it makes me feel. It helped me a lot with my nausea. I've heard it's safe and doesn't hurt the baby, but I guess I'm not sure. That is a very common perception. I have information on marijuana use in pregnancy, and I'd like to share with you, provide counseling, and share an educational handout. What are your thoughts on the information I just shared? On a scale of 1 to 10, how ready are you to make any changes in your use of marijuana? This is a readiness ruler. It's really helpful to think about a scale of readiness from 1 being not ready to 10 being very ready to make a change. The patient chooses a 6. A 6, that's great. Why did you choose 6 and not a lower number like a 1 or a 2? Well, like you said, if a joint might hurt my baby's development, I don't want to keep using it, but what about my nausea? We have other things that can help you with your nausea that are not harmful to your baby. I have other resources and people that patients often find helpful. Would you like to meet with them? Thanks for talking with me. Can we schedule a date to check in again soon? Sure. You're basically talking to your patient about their risks. You're linking them to treatment and resources. It is so important that the OB provider take the lead and manage this discussion with their patients. What is a warm handoff? We talk a lot about warm handoffs in optimal care for women with opiate use disorder. A warm handoff means helping in the process and making sure the patient has an appointment and follow-up set up. If a patient declines MAT or behavioral health recovery services, it's important to schedule a short interval follow-up with the MFM and the OB provider. It is not providing a phone number to the patient, having the patient call, or giving a list with resources to the patient. It is not just a phone call to a social worker with no additional follow-up. Warm handoffs are essential to making sure that our patients receive MAT and linkage to recovery treatment services. The OUD SBIRT clinical algorithm is an essential tool to be able to help OB providers and their clinical team understand the steps necessary to take care of patients with opiate use disorder. I want to lead you through this so that you can understand how you can use the clinical algorithm to make sure that the key components of care are provided to every patient with opioid use disorder every time, so that we can optimally reduce risk of overdose death for all of our patients. In green, providing universal substance use disorder, opiate use disorder screening with a validated tool. If someone screens positive, it may be that they just have risk factors, and that would need a brief discussion to talk about risk factors and risk reduction. If the patient screens positive for opiate use disorder, to the left side in purple, the OB provider needs to see the patient, provide brief intervention to assess diagnosis, counsel on risks, and assess readiness for treatment, what we just reviewed with expert. Below are some steps to take to link those moms to MAT. One option on the far left side, if the patient's having withdrawal symptoms and is ready to start MAT, is to admit the patient to the hospital for a fast-track MAT start. The patient can be stabilized on MAT at the hospital and then discharged into a recovery treatment program. If it's unclear if MAT is indicated, or if the patient is not ready to start MAT, or it is clear that outpatient MAT is available and the best step for that patient, then initiate outpatient stabilization with social work support and a warm handoff to behavioral health recovery treatment programs. Recovery treatment programs may be inpatient treatment programs, intensive outpatient treatment, behavioral health treatment support, or peer support programs. On the far right side is the OUD clinical care checklist. This is so important to initiate and to put into the patient's chart, so those that come later in the patient's care can understand what has been accomplished for this patient and what still needs to be done. Most importantly, send off a hepatitis C screen and provide Narcan counseling and provide a prescription. Serial tox screens are done with the patient's consent during prenatal care. A neonatal consult is important to educate the patient about neonatal absence syndrome and how they can engage in care. A social work consult. Patients may benefit from an anesthesia consult to talk about pain control in the setting of a woman with opioid use disorder. An MFM consult can help to coordinate care, and then contraception counseling. It's important to provide standardized patient education, as we discussed before. In the middle is how to document OUD and the problem list, and how to bill for expert, and also some hotline numbers to help OB providers that we'll be talking about later in this eModule. The MAT recovery treatment locations number 24/7, a way to find a local treatment option for your patient. And at the bottom, the Illinois Doc Assist, which is operational Monday through Friday, 9 to 5, for a free addiction consult for providers who care for pregnant and postpartum patients. Let's talk about creating a system to activate the OUD protocol for every patient. So what are the resources available to make sure that your team can provide optimal care for all patients with OUD? We understand that not every provider sees patients with OUD regularly. Some hospitals may rarely see a patient with OUD. But again, given this is a life-threatening chronic medical condition with life-saving treatment available, we need to be ready for that one patient, because that one patient may be the patient that you save a life. We want to make sure that every patient with OUD receives optimal care. This is so important given the high risk of maternal death from OUD. We need these systems to make sure that optimal OUD care is provided for every patient and every time. The following systems have been used by hospitals and prenatal care sites around Illinois to improve the care they're providing for patients with OUD. MNO folders are used by many hospitals and prenatal care sites around Illinois as a way to contain the resources for providers, nurses, and patients in one location for when a patient arrives and is identified with opioid use disorder. We'll be reviewing the steps for using the MNO folder and what's contained in the MNO folder in a minute during this eModule. Many hospitals have moved to using prenatal care team conferences and labor and delivery care team huddles in order to bring together a multidisciplinary group of providers in order to make sure patients are receiving that optimal care. For prenatal care team conferences, this is an important opportunity for obstetrics and neonatology, nursing, and social work to talk about a patient who's been identified with opioid use disorder during the prenatal setting and make sure that they receive the needed care, including linkage to MAT and recovery treatment services, Narcan counseling, neonatology consult, and other key clinical steps. Labor and delivery care team huddles have been implemented by many hospitals around Illinois to be used when a patient with OUD is identified on labor and delivery. These are often called by the primary nurse or the charge nurse. The huddle would include the obstetrician or MFM, nursing, neonatology, social work, anesthesia, and addiction medicine or psychiatry if appropriate. It is a great opportunity to be able to utilize the MNO folder and make sure that the checklist and care plan have being utilized and that optimal care has been provided. In order to remember the key steps for prescribing Narcan or for writing a hepatitis C screen or the consults that are being utilized, many hospitals have moved to using OUD order sets. An order set can help providers remember how to prescribe Narcan, which consults are needed, and simplify the process of making sure the patient receives optimal care when they arrive for the delivery admission. The MNO folders have been used throughout Illinois, both on labor and deliveries and in prenatal care locations, as a way to have all the materials together when you identify a patient with OUD so that you're ready to provide optimal care. The goal is to store folders on labor and delivery and in prenatal care locations so that when a patient is identified, a MNO folder can be obtained. In the MNO folder, there are patient education materials that can be shared and reviewed with the patient. These are really important educational materials that help them understand the benefits of medication-assisted treatment, understand neonatal abstinence syndrome, and how the mother and family can play such an essential role in the treatment of newborns who are opioid exposed. There's information on contraception counseling for women with OUD and other resources. On the right-hand side, you see the clinical team resources. First is the clinical algorithm that we already talked about. So important to have at your fingertips so that you know the optimal elements of care that you must provide in order to reduce risk of maternal death for these patients with a life-threatening illness, opioid use disorder. The clinical care checklist is also very important so that you know the key steps that you need to take. The clinical care checklist should be inserted in the patient's chart, either through a dot phrase if it's already in your electronic health record, or it should be scanned in if you're using a paper version. The reason the clinical care checklist is so important is so that the providers who are seeing the patient next knows what's been completed and what still needs to be completed for this patient's care in order to provide optimal care for this patient. The Narcan resources in the MNO folder are so important. It is essential that every patient with opioid use disorder receive counseling regarding Narcan, naloxone, and receive a prescription. In the MNO folder, the Quick Start Guide is a resources to provide to patients so that they understand how to use Narcan at home and their family understands how to use Narcan at home in order to save a life in the event of an overdose. The Save a Life resource is for providers in order to explain key steps for counseling and also exactly how to write a prescription. It is so essential that every patient with opioid use disorder is counseled regarding Narcan and has a prescription so that they have Narcan at home for them and also available to their family if needed. And finally, we have the nursing workflow. The nursing workflow is really important during the delivery admission and has an element which we will go over for labor and delivery nurses and also for postpartum nurses in order to understand the key steps nurses must make sure occur in order to provide optimal care for patients with OUD. This is what an MNO folder might look like. This is an actual hospital's example they sent us a picture of. And again, on one side, provider resources, and on the other, patient resources. It's really important to keep these folders available in both prenatal locations and labor and delivery for every OUD patient. And when you have an OUD patient, make sure to ask, does anyone have an MNO folder? It's going to make things much easier for you to provide this patient optimal care. The Ilpqc OUD clinical care checklist is an essential way of understanding the key steps you need to take during prenatal care. It goes through by trimester, during delivery admission, and postpartum. Most importantly, the key checklist items are seen here: assessing for readiness for MAT, linking to recovery treatment programs, Narcan counseling prescriptions, contraception counseling plan, and a hepatitis C screen. The nursing workflow resource that we mentioned has a side for labor and delivery nurses and a side for the postpartum delivery discharge nurse. An important way to make sure, as we hand off patients from one nurse to another, that the key elements of care for women with opiate use disorder are determined to be completed before delivery discharge. So essential to reduce the risk of maternal death for these patients in the postpartum period. Patient education resources available in the MNO folder. These resources have actually been created with patients with opiate use disorder who have a baby or had a baby in the NICU with NAS. These resources can be incredibly important to help empower women and understand their important role in taking care of newborns with opioid exposure. Providing these patient education resources from the MNO folder is incredibly important, and making sure that we go over the information with the patient. And finally, a neonatal or pediatric consult in order to go over OUD and NAS and maternal participation in newborn care, including rooming in, eat, sleep, console, and breastfeeding for opioid-exposed newborns. I commented on the Narcan resources available in the MNO folder. Again, it is so important to counsel and prescribe naloxone and Narcan for every patient. Remember that this is safe and easy to prescribe and is a key risk reduction medication that reduces overdose risk. We need to share that we want all women who take opioids to stay safe, that opioids can cause slowed breathing and accidental overdose. Narcan is a safety medicine as it reduces overdose and should be available for every woman who has opioid use disorder or uses opioids regularly. In order to prescribe Narcan, make sure that you use the Save a Life resource. It has the prescription there. There's also a code that you can use for an example prescription. Narcan comes in 2 packs, and we often tell the patient to put one in their purse and give one to their family. The top resource here, the Quick Start Guide, we give to patients and helps them understand how to use Narcan at home. The bottom resource, Save a Life, is really for providers in order to describe counseling and how to prescribe the Narcan naloxone. These are folders that you may see on your labor and delivery or in your prenatal clinic that have been created and shared around Illinois in order to help OB providers and nurses understand the maternal mortality crisis and how opioid use disorder has become a leading cause of maternal death, and the important components of care that we must provide to reduce risk of maternal death, including starting MAT, providing naloxone or Narcan prescription and counseling, and linking every mom to recovery treatment programs. On the left is a poster encouraging screening of all pregnant patients for substance use disorder and opiate use disorder with a validated screening tool. If you are not sure if you're using a validated screening tool at your prenatal care location, it's important to ask and make sure that you're complying with the ACOG standard of care and current recommendations for validated screening. Finally, I want to talk about a critical issue when considering how to provide optimal care for women with opioid use disorder. How do we make sure that our clinical teams understand the risks of stigma and bias? Substance use disorder is among the most stigmatized health conditions in the US and around the world. We know that standardizing care through protocols and checklists, like we've been talking about today, creates a space and provider openness in order to address stigma and bias. We talk a lot about old way of thinking and new way of thinking when we talk about opioid use disorder. We know that our patients' lives depend on us taking the time to understand and address our own way of thinking about opioid use disorder and make sure that we take an honest look at our own biases. Previously, when I would talk to providers or nurses or clinical teams about why they're screening for opioid use disorder, I think there was a general idea that we needed to identify moms in order to protect babies, that we were screening moms to identify babies at risk, and that the members of the healthcare team were the best people to provide care to opioid-exposed newborns. We have really shifted our thinking. We understand that we are screening moms in order to identify moms with a life-threatening chronic medical condition as early in pregnancy as possible in order to connect them to treatment and provide recovery resources to help put them in a position to be able to provide the very best care for their own newborns. We must make sure that as we think about taking care of women with opioid use disorder, everyone on our clinical care team takes a minute to think about their own biases and understand why we're screening, why we're testing, and why we're linking women to care. We need to understand this as a chronic disease with a life-saving treatment, medication-assisted treatment, and that it takes all of us to care for women with empathy and respect in order to help women get on the road to recovery. An important element of thinking about stigma is performing a language audit. We talk a lot about that words matter when we talk about opiate use disorder. It's important to perform a language audit of existing material and language that is used in your clinical team that may be stigmatizing and replace it with more inclusive language. So if you are using terms like addict, abuser, negative, dirty urine drug scene, we need to be thinking about moms with opioid use disorder, babies with neonatal absence syndrome, misuse, normal urine drug screens. Those words are stigmatizing, and we need to be thinking about moms with opioid use disorder as having a chronic, life-threatening condition with life-saving treatment available, and that the clinical care team is instrumental in helping link women to treatment and recovery services to help women recover. In thinking about stigma and bias, it's important to understand that stigmatization by healthcare providers is a key deterrent to prenatal care. This is why many women are late to prenatal care. They're embarrassed and they're afraid of how healthcare providers are going to treat them. Criminalizing substance use disorder in pregnancy is both clinically ineffective and ethically inappropriate. And provider encouragement and support for social services and opioid maintenance therapy programs increases patient follow-up and linkage to care. Providing compassionate care, judgment-free support, and close follow-up is what is absolutely necessary for best outcomes for both mom and baby. There's a short eModule available through Ilpqc called Why Words Matter that I encourage all of you to look at if you need more information regarding how to address stigma and bias in your clinical care team. Finally, I want to make sure that everyone is aware of the 2 hotline numbers here in Illinois to make it easier for OB providers to care for pregnant women with opioid use disorder. The Illinois Helpline for Opioids is a statewide public resource for finding local substance use treatment and recovery services in Illinois. It's open 24 hours a day, 365 days a year. So call that number to help find a local treatment resource for your patient. Another important resource that is new this year is the Illinois Doc Assist Warmline, a free addiction medicine consult service for OB providers caring for pregnant and postpartum women with OUD regarding MAT during the perinatal period. So if you have questions about MAT, or if you have a mom with opiate use disorder and you're trying to start MAT, please call this number, available Monday through Friday, 9 to 5. And if you call off hours and leave a message, they'll call you back the next business day. Finally, I'd like to review the key points we discussed today. Drug overdose is the #1 cause of maternal death in Illinois. Pregnancy is such an important window and opportunity to identify these moms and provide them the treatment that can save their lives. Linking to MAT and recovery treatment services saves lives. This has to be the responsibility of obstetric providers and the OB clinical team. We must be able to take care of these patients. There are key steps that OB clinical teams need to take prenatally and on L&D to care for women with opioid use disorder. Use systems such as MNO folders, labor and delivery huddles, and OUD order sets to provide optimal OUD care for pregnant and postpartum patients, every patient, every time. Provide and document universal substance use disorder and opiate use disorder screening with a validated screening tool. You must confirm that you are providing the screening for every pregnant patient as early in pregnancy as possible during prenatal care and on arrival for delivery admission. This screening is necessary for all patients. For women with OUD, we must counsel and assess readiness for treatment, link to MAT and recovery treatment programs with a warm handoff. We must initiate the OUD expert clinical algorithm. Remember, it starts by going in and talking to your patient. Complete the OUD clinical care checklist. This will help you know that you have provided optimal care for your patient to reduce risk of maternal death from OUD. Provide Narcan and naloxone counseling and a prescription for all women with OUD or who use opioids regularly. Remember that there's an example for counseling and a prescription example in the MNO folder. Educate every mom with OUD on OUD and NAS and engaging in newborns care. It's so important to empower moms to engage in newborns care and help them understand their newborns care and how they can participate. Confirm warm handoffs for linking to CLEAR and close follow-up. Every patient with OUD needs that 2-week early postpartum visit, and they should be followed closely during prenatal care to make sure that they're linked to the services and treatment they need. Actively reduce stigma across your clinical team. Words matter. These moms need our empathy, our support, and our care. Remember, in order to reduce risk of maternal overdose and achieve our goal of reducing maternal mortality from opiate use disorder and improving pregnancy outcomes, we must identify every mom with OUD, so we should be screening prenatally every patient with a validated screening tool. If you are not doing this in your office, please consider the steps needed to get this done. Remember, for every patient identified with OUD, we must assess readiness for MAT and link them to recovery treatment services. Every patient needs risk reduction strategies to reduce risk of overdose, including counseling for Narcan and a prescription. These are the key steps needed to reduce risk of maternal overdose deaths from opioid use disorder and provide optimal care for every mom with OUD. Thank you for listening today. If you have any questions regarding materials we reviewed, please visit us at www.ilpqc.org for more information. Thank you to our funders and our sponsors.